Hello everyone, my name is Cynthia Hunter and I will be analyzing the social cognitive theory. The social cognitive theory was first conceptualized by Albert Bandura in the 1960s and was originally named the social learning theory. In 1986, it was renamed to the social cognitive theory when self-efficacy was added to the construct. SCT focuses on determinants of behavior and methods for behavior change through an individual, and it explains how human behavior, cognition, personal factors, whether that be internal or external, and the environment interact to promote behavior change. Through the past and present observations of personal behaviors and the behaviors of a person's social environment, a person is able to develop self-efficacy, which is one's own confidence in being able to make a behavior change. And after the behavior change has been established, a person uses a reinforcement technique to help maintain the behavior. Here you can see the infographic that I've created for the social cognitive theory. It outlines the 6 major components of the theory itself, and I've also noted some limitations. So we will go through all of these things throughout the presentation. Here we have the 6 components of the social cognitive theory. First off, we have outcome expectations, which are one's perceived consequences of a behavior and can be either positive or negative. And then outcome expectancies, which are the perceived benefits. The social cognitive theory is centered around self-efficacy, which is a person's confidence in performing the desired behavior. Behavioral capability, which is an individual's actual ability to perform the behavior, and is also influenced by the perception of behaviors of people around that individual. So the last component is a person's environment. In this environment, a person draws strength from the influencers around them. So an individual applies SCT by evaluating their own actions and results, and by observing others' actions and results. To help a person achieve behavior change, the individual would set small and achievable goals and specify their rewards, whether that be monetary, mental, or physical, and use reinforcement techniques to substantiate the behavior change. This is done through an active learning process which promotes performance during the learning process. Now I'd like to elaborate on 2 case studies where the application of the social cognitive theory has been used. The first off is the Wise Woman Public Health Intervention. The Division for Heart Disease and Stroke Prevention, which is run through the Centers for Disease Control, has created the WISE Woman, which stands for Well Integrated Screening and Evaluation for Women Across the Nation, Public Health Intervention to decrease cardiovascular disease in women. The target population are women who are uninsured and have low income status and are aged 40 to 64 years old. Several studies have been completed using different types of models, such as randomized control trials, quasi-experimental case studies, and mixed method evaluations. Multiple behavioral theories were tested for this intervention, but a high success rate was noted by using the social cognitive theory using enhanced interventions. Counseling sessions were targeted at developing a higher self-efficacy through individualization, social support, monitoring, and reinforcement. And this has shown extreme success for this intervention and is actually available in several states throughout the United States. There are some definitely pros and cons to the Wise Woman Public Health Intervention. Some pros that are noted would be the intervention using social cognitive theory, that the behavior techniques are made to occur at the individual level, meaning that a new mindset is created and reinforced through some type of a reward system. It also focuses on building self-efficacy and one's own judgment of his or her capability of actually being able to accomplish the goal. And if outcome expectations are strong, then self-efficacy increases. This means that the women are taught to use I statements, which promote self-confidence. So for instance, if we're focusing on cardiovascular disease, women are taught through these counseling sessions to make statements such as, I can stick to a low-fat diet. And what's nice about these is that the interventions are also modifiable through SCT, so the interventions can be tailored to individuals, which if they can get their social support involved, you can increase the intervention at a bigger level. So some cons to this intervention is that it's not available in all 50 states. And it's also not targeted to women of all age groups who are uninsured or low income. And women in their early 20s are definitely at risk of cardiovascular disease later in life. So it's important that we make these changes when they're younger. More so, using SCT to decrease cardiovascular disease in this population is that in a clinic setting, this theory relies on more one-on-one treatment from a physician or some type of healthcare professional to promote such a behavioral change. This can make reaching a larger population more problematic. And due to this barrier, an overall change at the organizational level is crucial. Another barrier to this theory is the lack of environmental engagement in the socio-ecological framework. So to successfully decrease cardiovascular disease in this targeted population, the change needs to happen on the individual level, meaning their self-motivation. And sometimes this can seem like an unachievable goal for some women. The second case study that I would like to analyze that used the social cognitive theory is actually a public health intervention in Mexico, and it is called the Niño Santo, Adulto Santo public health intervention. And it was recently put into place to decrease the development of childhood obesity in the Hispanic population. The targeted population are Hispanic mothers who have school-aged children, and the interventions focused on meal planning within a budget and how to use this budget to cook easy meals, quick meals, but that were also healthy. Intervention mapping was used in this study to provide structure to these mothers so that each step builds upon the next. And evaluation methods focused on the children's eating behaviors to evaluate the effectiveness. Children were asked after the study how they felt about eating healthier, do they feel as though they are more active, and their cognitive capabilities were assessed to determine if the children had the mental capabilities to ensure long-term success. The mothers were also evaluated after the program to see what their support was like, how are they maintaining at home, and how they feel about the health program. There are also some pros and cons to this study as well. So some pros are that it was largely built around the mother's social environment and family structure. The mothers were able to pinpoint their perceived barriers to promoting a nutritious lifestyle, which helped identify positive and negative food behaviors that their children were experiencing. And the mothers were also able to identify internal and external barriers that are maybe influencing their self-efficacy. Some of them lacked confidence in the ability to cook nutritious meals and limit their children's sugar intake, and sometimes this was due to family members in the household as well. So some cons that were noted throughout this study is that the majority of these women reported a lack of spousal support. So their husbands would complain about drinking more water and they would want soda kept in the house, which having those unhealthy items in the house doesn't always promote a nutritious environment. You have to rely on an individual to make those changes. And this led to an increased dropout rate from the program. So mothers also reported that grandmothers who were primary caretakers for their children while the mother was away working or out of the home stated that the belief system for nutritious foods and beverages were not upheld while the mother was out. So this also led to more low self-efficacy for these mothers due to the feeling that they were out of control in their situation. So the issue with the social cognitive theory in this instance is that change is so promoted at the individual level that sometimes it's hard to have a family unit come together to be able to make these changes, which is why the environment is so important as well in order for this theory to work, is that it really is not just the individual, but it's their social circle and who they're around, and are these people participating in the program so that the change can be more family oriented in this instance, which can make at times getting it to a community level difficult. So let's identify the gaps that are in the constructs of the social cognitive theory. So SCT relates behavior to the environment, alluding to the fact that environment will create change due to a social mindset instead of individualism. So it's believed that the interplay between person, behavior, and environment are all the sole contributors to behavior change, but fails to articulate which element may have more influence over the behavior and why. It also focuses more on individual making a change, and although influenced by social environments, this type of construct is hard to apply to large populations, which can hinder if you're using this theory to promote public health interventions. Past behaviors are also taken into account for learned behavior, but SCT fails to recognize the biological and hormonal constructs that are also attributed to behaviors. So some people may not have the mental capability to make a positive change. Although there are several benefits to the social cognitive theory, there are elements or additions to the theory by promoting change across multiple levels. So going beyond the individual, approaching behavior change at the organizational level, such as with exercise, may yield bigger results. So for instance, if an individual is motivated to exercise due to the social support of a coworker, physical activity is more likely to take place if the organization offered a site with appropriate equipment. On the other hand, policy changes in the workplace, such as an on-site clinic, would increase access to a practitioner, physician, or even a nurse to provide free healthcare checkups and education to promote a more healthy or physical lifestyle. A study completed by Dewar, Lubens, Plotnikoff, and Morgan in 2012 noted that through qualitative and quantitative data that teens are more likely to embrace healthier eating habits when combining SCT with self-determination theory versus non-theoretical interventions. So these facilitated pathways for the facilitation of the actual behavior and the intervention and behavior outcomes. There are also additional frameworks or theories that you can add to the social cognitive theory to make it more effective. If you were to add frameworks such as the trans-theoretical model of behavior change to the social cognitive theory, I like this because it promotes a planning stage. So someone has a goal, has a target, they've set their mind to this behavior, and then they're going to focus on maintenance of the behavior change. And the end goal is for termination of the unhealthy behavior. So if you were to combine multiple theories or even frameworks of non-theoretical constructs, you would have a higher success rate, I think, when using the social cognitive theory. So I'd like to thank you all for listening to my presentation. If you have any questions or have thoughts or feedback, I look forward to discussing it in the discussion. Thank you so much.